Hello, 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 and welcome to this wonderful production here on blackdoctor.org. I am Ellis Dean, the Director of Digital Program and Production at Black Doctor, and you are here watching season 2 of Open Your Eyes. This is our series on diabetic retinopathy. And so you might be asking me, well, what is diabetic retinopathy? You're about to find out, and we're about to tell you because we've got two great experts that we're going to talk about all things related to diabetes and specifically diabetic retinopathy, diabetic eye disease. And so before we begin, there's a couple of things I need you to do for me. Number one, I need you to let us know where you're watching from. And that is just drop that in the comments. Drop your city, your state. You could drop your high school, your favorite teacher, whatever you want to do. Just drop that in the comments. Let us know where you're watching from. We'd like to know where people are watching us from all over the world. Number two, if you know somebody that needs this information, tag them or share this on your page. We want to get this information out to as many people as possible, particularly those people, and we're going to learn what this term means tonight, pre-diabetic, or people that might be that are diabetic. And pre-diabetic is a huge category, folks. So we want to not only get people to get their eyes checked, we want to get their blood sugar level checked, their A1C. And we're going to talk about what all that means tonight on tonight's program. And then finally, the third thing I need for you to do is if you have any questions throughout the program, I see Upstate New York checking in. If you have any questions throughout tonight's program, I need you to drop that in the comments and we will get your questions asked and answered because you've got two of the nation's best experts. One is on diabetes, and that's Dr. Coleman, Dr. Lenore Coleman, who you know, we got UK in the house. Cheerio, how are you doing? And we also have Dr. Joe Coney, who is an ophthalmologist, and he is a retina specialist. And did I get that correct, Dr. Coney? He is a retina specialist. And so we're talking about with a diabetic eye disease. So we've got both ends covered. We've got the diabetes side. We've got the ophthalmology side. So you didn't sign on to hear me talk. So we're going to get into this evening. Welcome to you both.
Thank you very much for being here.
Thanks for having me.
So Dr. Coleman, we'll start with you. All right, so help people, just give us a general understanding of what is diabetes and what is the prevalence of diabetes, particularly in Black Americans.
Okay, so diabetes is basically the inability of the body to be able to handle the sugars that you eat in your diet. All right, so we're really worried. I know you guys, a lot of folks out there are on keto diets and all sorts of other diets. So you've heard this word carbohydrate. Well, carbohydrates basically are your breads, your potatoes, your rice, all of those things that taste really good, but are really damaging for those people who have diabetes. Those carbohydrates, those sugars and those starches increase your blood sugar, and that's called glucose. Right. So, in fact, Black folks maybe have heard their families call it that I got a touch of the sugar. Or my doctor says I have a little sugar. Okay, well, that sugar is diabetes, and there is no such thing as a little bit of sugar. You either got diabetes or you don't have diabetes. So it's like being a little bit pregnant. There ain't no little bit pregnant. You're either pregnant or you're not pregnant. Okay, so there's a lot of folks, because they have sort of minimized that high sugar, they don't think that diabetes causes a problem. But when that blood sugar, and I always have to talk about numbers, because what I do in my line of work is make sure people know their numbers. All right. So when I'm talking about glucose or blood sugar, that glucose number that I worry about is anything over 100 milligrams per deciliter. So when you go to your doctor's office and they draw your blood, they usually run a blood glucose test. And next time you go see them, you need to, before you leave that office, you need to say, hey, doc, print out my lab work so I can see it, and you can explain to me everything that says high. Because when they do your lab test, that lab test says high, that lab test says normal, or that lab test says low. It says it on the piece of paper. And so you need to be concerned about everything that says high or everything that says low. All right. And so if your blood glucose is high and it's higher than 100, then that means you might have prediabetes. And Ellis kind of talked about that in just a minute. So there are millions of people that have prediabetes. Prediabetes is when your sugar is between 100 and 126. All right. So when I say millions, I'm talking about 96 million. There's a whole bunch of them. And a lot of those people are African American or people of African descent. And it's just because it's something that we're just predisposed to. There's a high prevalence. There's a whole bunch of things that Black folks got that no everybody else doesn't have. And a lot of it has to do with our eating habits. And a lot of that had to do with slavery and the kinds of food that we ate during slavery. So that soul food that everybody's out here standing in line to go get, that was food that the slave master used to give us. And we figured out a way to take those scraps and those leftovers and make them taste good. Unfortunately, they taste good, but it causes your blood sugar to go up. So this is a problem. So when you are eating all of those candied yams and macaroni and cheese and putting that pork in them greens and collards, all of that stuff is not good for your blood sugar. It's not good for your weight. And the thing that people need to know is if you're overweight, it makes your blood sugar go up, especially if you have diabetes in your family. So all of these are things that people just don't know about. And that is why we see so much diabetes in the African-American community.
Well, look, you just made me hungry and then not want to eat soul food at the same time.
I'm sorry. You can have a little bit. You can have a little bit, but not much. Yeah.
Okay, so we understand what diabetes is. So you talked about, but I've been hearing this thing on the commercials, right? So you said blood sugar and you said 100, but I've been hearing this fancy term on the commercials called A1C. Yes. What is that in terms of the number? And then is that a different number than what you said? Because you said 100, but I'm hearing those A1C numbers being under 10 and around then. Yeah. So what is the difference between what you said, blood sugar, glucose, and A1C?
Yeah, so blood glucose is measured in it's just really fancy milligrams per deciliter. So it's 100, less than 100 is what we want you to be. Prediabetes is 100 to 126. Diabetes is 126 or greater. Hemoglobin A1C is what every person that has diabetes or diabetes in their family should be doing yearly to see if you have either prediabetes or diabetes. Hemoglobin A1C is the same hemoglobin that carries the oxygen to your body. Everybody's heard about hemoglobin. They know it carries oxygen. Well, that hemoglobin molecule, which is inside the red blood cell, right? Everybody's got red blood cells, right? Your blood. Inside that red blood cell is something called hemoglobin. It carries your oxygen, but there's a part of it called the A1C component of the hemoglobin molecule. So they found that glucose, that sugar in the blood, attaches to that A1C component during the life cycle of the red blood cell, which is 120 days. So if your blood sugars are high, and I take the A1C test every 3 to 4 months, I will be able to see your number is high. So what is high? High is anything higher than 7. 7's your number. You need to be less than 7. All right. If you're elderly, I'll let you have 7.5. But other than that, you need to be definitely less than 8% because it's measured in percentage. So if I have a patient that comes to me and their A1C is 9%, that means their average blood sugar stays in the 200s or higher. So that 9%, you say, oh, that's not so bad. It's only 9. No. It actually equals what your blood sugar is, your average blood sugar is. So if you right now go on Google and put in A1C chart, you'll get a chart that'll show you what your A1C number is compared to your average blood sugar. And we want your average blood sugar to be below 160. It shouldn't really get higher than 160. That means your A1C will be less than 7%, which is where we need you to be. People with diabetes should get an A1C 3 to 4 times a year, every quarter. And especially if it's not below 7. Now, if you're good, if your A1C is good, then you can get it maybe twice a year, once a year. But if you're not at your target numbers, you need to be getting it at least 4 times a year.
So that is fantastic. And so we're understanding, and this is, so help me if I'm wrong on this one. The A1C gives you a 3-month span. So it's a little bit better because when we're talking about that blood sugar test, that can be spiked. If I eat a Snicker bar, my blood sugar is going to go up really, really high. So if I took a blood test right after I eat a Snicker bar, I might push over 100. If it was, oh, you're pre-diabetic, well, I'd say the Snicker bar.
Right.
But that A1C is what my blood sugar is averaging out over that 3-month span. So that's going to give me a kind of over time depiction of my blood sugar, which is why you're seeing those commercials, all those commercials you see all over and they singing and dancing, everybody fishing or whatever they're doing in the commercials. I love the commercials, but all the stuff that's going on in the commercials, reason why they keep talking about A1C is because that can give you your blood sugar over time, and that is a better picture than just that snapshot. So like
exactly, yeah. So it's your average blood sugar over that 3 to 4 month span, and it's all of your what it is it's all of your highs and all of your lows added up. That's what an average is, right. And so that gives you a good idea of what's happening with your numbers.
Okay, so let's talk about some of the bad things. What can happen if somebody has uncontrolled or poorly controlled diabetes?
Okay, so right now, this is my year for Healing Our Village, which is the name of my company. For us, this is the year of the kidney. All right, so I am focused on high blood pressure, which almost every person with diabetes has, especially if they're African American, and the fact that those high blood sugars and hypertension lead to chronic kidney disease. So there are too many African Americans on dialysis. All right, so your kidneys, our topic tonight, your eyes, and your nerves, all of those are what we call small vessel complications, microvascular complications. All right, so we know for a fact, there's data that we've had for years, that if your blood sugars are high, it causes you to have those complications, right? Because those small vessels in either your kidney or your eye or your nerve endings, all of those can be affected by that high blood sugar and causes you to have either neuropathy, which is the nerve problem, nephropathy, which is the kidney problem, or retinopathy, which is the eye problem. Okay, so those are small vessel diseases or nerve diseases. But diabetes also, if your blood sugars are uncontrolled and they are high, it can cause what they call big vessel disease or macrovascular disease. That's what causes the heart attacks and the strokes. So that high blood sugar is affecting the lining of your blood vessels. They're making them weak. They're making them leaky, just like that does with the smaller vessels, right? And can cause your heart to have to work harder. And if your heart works harder, it can cause it to have a heart attack. Or if you get the vessels in your neck going up to your brain, if they get clogged up and clots form, then that's how people have strokes. Mm-hmm. So diabetes is really a vascular disease. It affects your blood that's circulating through your body, and it affects your actual tissues and your vessels and your nerves. So that is why when people have had diabetes for 15, 20 years, where they've had high sugars, they start to have all of these complications.
Wow. Okay. So you dropped some big words there: microvascular, macrovascular. I got to look this. I got to get my dictionary out, but I get the point. So microvascular are those small blood cells, and we're going to talk about that with Dr. Coney because there's a lot of micro blood vessels going into our eyes, and the eyes are very important. And so what happens is when they start shredding, but we're going to let Dr. Coney tell you that because I'm not the one that's for that. But I will. Finish with this. When we're talking about diabetes, what are some of the symptoms that somebody can notice on their body that says, hey, my blood sugar might be out of whack? Because I don't know, unless I take a test, I want to know what my blood sugar is. Are there some outward signs that I can see or somewhere that I feel that can show that my blood sugar level is getting above normal?
Yeah. So there's something called the 3 Ps. So that's polyuria, means you're getting up, going to the bathroom, especially at night. So if you're getting up 2 and 3 times to use the restroom at night, then that is a sign that there may be something going on with your kidney, and maybe you have some problems with your blood sugar. So polyuria, polydipsia. If your blood sugars get really, really high for prolonged periods of time, all of a sudden you're just super thirsty. You can't get enough water. And that's what polydipsia means. So it's polyuria, polydipsia, polyphagia. That means you can't get enough to eat. You're just hungry all the time. You're losing weight, but you're eating. And you can't stop, and you can't get enough to eat. That's your first 3 signs of diabetes. But there are some other subtle signs, like we talked about the nerves and the nerve endings. If you have numbness and tingling in your fingers or your feet, if your feet are cold, and you don't understand why, you got to put socks on. You can't, your feet are freezing, but the rest of your body's fine. That could be a sign of diabetes. If all of a sudden you're going to your dentist often because you got a bunch of dental cavities, that can be a sign of diabetes. The blurred vision, that could be a sign of diabetes, because Dr. Coney's going to talk about retinopathy, but he's also going to maybe talk a little bit about cataracts and glaucoma. All of these things could be possibly because of diabetes. So if you're going to your eye doctor because your eyes keep getting worse and worse and worse, and you don't understand what's going on, could be a sign of diabetes. And then if, let's say, you hurt yourself, and that wound that you have, it doesn't want to heal. You used to remember just hurting yourself, and then it would scab right over and you'd be fine. But all of a sudden now this one just doesn't seem to want to heal. That could be a sign of diabetes. So all of these are your typical signs that people don't think about. Another one for women is all of a sudden you got all these vaginal infections. So you're always going to the pharmacy getting some yeast creams for your vaginal infection. Very common sign in women that there might be something going on with their blood sugar. So those are your common signs that people talk about.
Wow. Okay. That was like, thank you for a crash course in diabetes. Not only was it informative, it was entertaining. So we definitely want it, but I love that, because you kept us engaged and really taught some good things. The 2 polys, like polyuria and
polydipsia, polyphagia, the 3 P's. That's what we learn in medical school, right?
Okay, so the 3 P's, I'm gonna remember that, right? So now we'll be thinking like every time I want some water in my diabetic. So, Dr. Coney, Dr. Coleman just mentioned about the what was the word again? The microvascular situations. And isn't that kind of the basis for retinopathy? So kind of get our audience to understand how diabetes impacts the eyes and can start causing retinopathy.
So I'm a microvascular surgeon where I work in the eye. So I'm a retina specialist, and my specialty is diabetes. And what people don't know is all these things that Dr. Coleman talked about is that diabetes is the leading cause of blindness in the working population. And so it's very common. How it causes diabetes, that chronic blood sugar over time, because diabetes is a chronic problem. It just can't cut the switch off. And over time, the high sugar starts to damage certain tissues in your body, i.e. those small vessels and those nerve endings. There's nothing smaller in the body than the small vessels in your retina. And when when the retina vessels become affected, they start to lose their structural support. We call them aneurysms or microaneurysms. And these microaneurysms become leaky. Dr. Coleman mentioned earlier that diabetes causes leaky vessels. Well, when I look in the eye, I can see leaky vessels. I am one of those doctors that can take a little small glimpse in someone's eye and kind of know where they're going to go. The most important thing to me is the level of which someone presents to me with their diabetes, because it tells me where they will be in the next 2 to 5 years without therapy. So when those vessels become leaky, the most common reason why people lose vision is that swelling that accumulates in the middle of the eye. That's called diabetic macular edema, and that is the leading cause in diabetes. There is a whole a progression of retinopathy where you have abnormal blood vessels to normal blood vessels, but as the disease progresses, the body then gets starved of oxygen. So when the oxygen tension is low in the eye, you develop abnormal blood vessels. We call that proliferative diabetic retinopathy. And those vessels, they are very leaky. They're very weak. They're very fragile. They bleed in the eye. And sometimes those blood vessels we call scarring. You get holes in the retina detaches. And oftentimes these, unfortunately, will require surgery. I think the most important thing is screening. Dr. Coleman mentioned great things about pre-diabetics and diabetics, but I think the most important thing that all these patients can do, besides seeing their medical doctor, endocrinologist, is go and get an eye exam. The problem with type 2 diabetics, we don't know how long someone's had diabetes. So at the time of diagnosis, they should go in and get a dilated eye exam. If you're a type 1 diabetic, we want it around adolescence or after or if they're really young, 5 years after they were diagnosed, because it takes time to develop the level of disease. But typically, there's no signs or symptoms with diabetes. And because it's a chronic problem, it's a late manifestation. So when someone comes and see me, I know they've had diabetes for several years, although they may have just saw Dr. Coleman last week and she started on medication. If I look in their eye and they have aneurysms and hemorrhages and cotton wool spots and all these other things, I know they've had diabetes for a longer period of time, or their sugars or their blood pressure has been high for a substantial amount of time.
Wow. Okay. So you use the fancy term. So I'm going to break it down for those of us that sat in the back of the classroom, because I know you were in front of the classroom guy, Dr. Conan. so the special thing, from what I understand, because I did read a little bit, what I understand, the special thing about the eyes are this: your eyes are going to try to protect themselves by developing some other blood vessels to continue the blood flow going properly. And you say, hey, that's a good thing, but it's not a good thing, because those blood vessels that get developed aren't as strong and they tend to shred and leak. And that's when we have the blood that's pooling and we get the blurred vision. Is that kind of the layman's term way of explaining what you just told us, Dr. Coleman?
So, Dean, I want to keep on the same dialogue that Dr. Coleman has teed up, because I think she teed up a really great journey of a patient by breaking down small vessels and large vessels. Okay. So let's go back to the heart. When those large vessels are affected and someone has a heart attack, over time, people develop collateral vessels, and in the heart is very good. You need that collateral circulation for the oxygen tissue that may not be well functioning, and that kind of helps people out. You know, if I have a massive heart attack and an 80-year-old have a massive heart attack, I'm going to be the one to die because I don't have any collateral vessels. So those collateral vessels will help you through those difficult times. In the eye, the vessels that grow, they're abnormal. Instead of growing flat in the retina, they actually use the vitreous gel in the eye called the vitreous humor. They grow up into the vitreous humor and grow like a grapevine. So vitreous humor moves around, it shears those little abnormal blood vessels. And that shearing of those abnormal blood vessels causes bleeding in the eye. To know that someone's bleeding, oftentimes sometimes floaters people will describe, or just a sudden loss of vision. Oftentimes, these are diabetic vitreous hemorrhages that have resulted from abnormal blood vessels that have gone undetected.
Wow. Okay. So you got floaters in the eye. And so if you're having, is that temporary, where you'll have some vision loss in one eye or both eyes at the same time?
So, diabetes is complicated. Individuals have different journeys. It could be both eyes. It could be one eye. Sometimes they can have vessels for a long time and they could be doing something strenuous. They can cough. That may be a warning signs. It may just be a couple little floaters where the blood just kind of goes away. Because the problem with diabetes early on is that there are no symptoms. You can have very advanced diabetes and still be 20/20. And that's the reason why screening exams are critical. The problem with diabetes that, once it starts to impact your vision, as a physician, I cannot always get your vision back. Most times we can stabilize it with aggressive therapy, but that therapy is really aggressive, and it includes injections and lasers, and that's a whole different discussion. But if you don't control that, we know from different levels your risk of developing vessels. Let's say if you have severe non-proliferative disease, which means you don't have any bleeding, that can happen 50% within a year, and really advanced disease within 5 years.
Okay. So when is somebody, first, I guess the first question is retinopathy a diagnosis? And if it is, when is it diagnosed, or when is it you're saying, okay, you're showing early signs of retinopathy? And so when do you cross that line from being early warning signs to actually having retinopathy?
Well, again, this is one of the things that we can see early in the disease. Oftentimes, patients are not aware. They may come in for a routine exam from an endocrinologist because they have been diagnosed with diabetes, or they have a hard time reading or driving. These are common things, and maybe just because that maybe just be their cataracts. They may not have much retinopathy at all. But when you have diabetes, it also increases your risk of cataracts, because the lens in the eye, which helps you focus the eye, which is the cataract we're talking about, it grows faster because the sugar gets deposited within that lens. And when your sugar is high, your lens swell, and then you can't focus. So sometimes you hear people say that, I know my blood sugar is high because I'm blurred. They're blurred because that acute incident they have caused the lens to swell, and then you can't see. But we can look in the eye from day one and know if someone has diabetic retinopathy. It's really easy. Just by dilating the exam, I can look into anyone's exam and know they have some type of retinopathy. This is, I just have a little lens. There's no fancy equipment that I need. We do use different imaging to diagnose diabetes, but just to look in the eye, we know if someone have retinopathy. It just takes a couple of seconds.
Okay. So, Dr. Coleman, what are the current treatments for diabetes in general? And what are and I'm going to take it one step further. What are the most effective treatments for Black Americans, since we're here on blackdoctor.org?
Okay. Well, that's really an interesting question, because things have changed. I've been at this for 40 years. And over that 40-year period of time, I have really seen a lot of new medications come out on the marketplace. But this last 10 years, there have been more newer agents that have been produced on the marketplace than I've ever seen throughout my career. So that caused the diabetes medication guidelines that are put together by the American Diabetes Association and the Association of Endocrinologists, clinical endocrinologists. Those guidelines changed actually this year. So this year, instead of us saying, I would have answered that question a year ago or 2 years ago, that metformin is the first line of therapy for the management of diabetes. But now I can't say that, because the guidelines now are saying that it really depends on if you have kidney disease or if you have heart disease, especially heart failure. So based upon those two conditions, your first line agents now are the SGLT2 inhibitors. These are drugs that didn't even exist 5-10 years ago. These are drugs that affect the kidney. And so, they always come up with a new mechanism of action for hyperglycemia, for high blood sugars, when there's a new drug that can actually affect that particular organ system. So they came up with this new class of medications, SGLT2 inhibitors, that decrease blood sugar, but they also, in their long-term outcome studies, showed that some of them have a beneficial effect on the kidney. And so it actually decreases your rate of proteinuria, of spilling protein in your urine and going on to develop chronic kidney disease. There are also studies now in that class of medications that show that it decreases your hospitalization for heart failure, and actually is beneficial not only for your heart, but for your high blood pressure as well. So that class of medications is now what we consider to be first line therapy. Mm-hmm. After that, then you start adding on maybe the DPP4 inhibitors. That's your sitagliptin, all right, mm-hmm. and anything that ends with the word gliptin. So linagliptin, sitagliptin, all of those belong to that class. Okay. All of it depends on that next drug you add. Depends on where your A1C is. Mm-hmm. Okay. So if your A1C is greater than 9%. Then they recommend the first thing you do is get on insulin, because we got to get those numbers down. Once we get your numbers down on the insulin, then we can maybe explore trying to use an oral medication. Mm-hmm. But the first line drugs now belong to that SGLT2. Now you can add metformin. There are still people that are out there using metformin. It can either be added as a second line or a third line. It really depends now. So now the medication treatment of diabetes has become an art form. It didn't used to be like that, because we didn't really have that many drugs to use. There's some injectable drugs that are called GLP-1 injections. That the big commercial everybody's looking at is that Monjour, right? That's the one. That's the big one where the folks are dancing around. She's dancing around because of Ozempic. That belongs to that same class, right?
Mhm.
So you see her. These people, Jardiance is that class of that
That's another
first
one,
line.
right?
You know, those people are. That person's dancing around too. I can't remember which one of the ladies dancing around. And
I
she does.
got that Ozempic. I got that Ozempic song in my head right now.
Yeah, that's right. It's all about Ozempic. So those are the drugs that are new to the market, have the most marketing dollars. So that's why we're seeing so much of them on the commercials. Metformin's been around for 40 years, so it doesn't have any marketing dollars. So you don't see that on the commercial. I myself like the GLP-1 injections, and Ozempic is an oral as an oral pill that is available. I like that class of medicines because it decreases your hunger. It takes away your appetite, and that's a big deal because most people that have diabetes are overweight, and they struggle with trying to lose weight because they have high circulating levels of insulin. They have hyperinsulinemia, high levels of circulating insulin. And what insulin does is store fat. So it's really hard to lose weight if you have diabetes because most people with diabetes have high levels of insulin. So these drugs that actually decrease insulin levels, I like those drugs because they tend to be able to help you get the weight off as well. So some of those drugs actually, in fact, we did a show on
we did.
the use of these guys, some of these diabetes drugs in higher doses for weight loss. And so you'll see those being advertised as well on the television. Yeah. So that's really sort of where we are right now in 2023. The thing I just want to tell your audience is that the treatment of diabetes is not a one size fits all.
Yeah.
So you really have to understand your physiology of diabetes for you to pick the right drug combination of medications to use, because one drug usually is not enough to treat your diabetes. It's going to take 2 to 3 medications. So you need to be on that right combination, and most people are not.
And Julie, just to add to what Dr. Coleman just said, and for us, it also helps out the eye. We know that the adipose tissue, particularly abdominal fat, is you're more prone to be insulin resistant. And we know that the adipose tissue around the belly also increases. Those individuals have a higher rate of having a diabetic retinopathy. So just by losing weight, you can start to have better control of your diabetic eye disease. So it's really crucial that these medications have really, I've seen retinopathy improve significantly. Now there's a transient part, because once your sugars get under control quickly, sometimes there's an effect in the eye where the eye would get worse, where the diabetic edema will actually leak in the eye. Okay, that's a transient effect. Long term, patients do much better once their sugars are better controlled and once they also start losing the weight.
So June is Men's Health Month, so I'm going to say this directly to my brothers out there. That spare tire that you hold it around, it could be impacting your eyes, right? And once your vision goes, you can't get it back. And I think Dr. Cody, and how important is your vision to you? So let's let that tire go. Let's let it go. Push back from the table. Lord. Just saying. So Dr. Coleman talked about a general treatment plan for diabetes. It is specific to the person, but she kind of gave us a nice overview of medications. Talk about treatment of retinopathy. What does that entail in terms of how it's treated?
Well, in our field too, the landscape of treating diabetic eye disease have really changed, particularly over the last decade and a half. We have developed certain therapies, certain biologics. These are injections that go in the eye that actually can decrease levels of eye disease. Before that, the only thing we had was lasers. We treat lasers for those leaky blood vessels. We had lasers for those abnormal blood vessels and bleed in the eye, and those scar tissue with traction retinal detachments. But now we actually, if we detect diabetes early, we can actually turn back the hands of time even before they have sight-threatening problems. And so, I think the problem that we have is that it's a burden for our patients. We know that once you have diabetic eye disease, you are 2 to 4 times more likely to have other problems. Heart disease, nephrology, peripheral neuropathy. You go into the hospital more, whether it's inpatient or outpatient. There's multiple doctors in your life. And so to come in every 4 to 6 months, which oftentimes that's the initial therapy in order to control someone's diabetes, is very difficult. Now, I'll say this gingerly, but most of us agree with this, but I don't think it's always true. I just think life happens. But diabetics tend to be a little bit more non-compliant. Sometimes they end up in the situation because of the lifestyle, how much they smoke, how much they eat, the inactivity. These are all things that we have control over. Just not going in to your doctor, not having your screenings. But then life happens where there are barriers to going to see your doctor. How far you live from your doctor. Can I just pay my copay? Do I have someone to watch my kids because I'm watching my kids. And so sometimes they cannot always make it to the doctor. And so therefore, once they get off their therapy with their injections, we see a relapse. And so you start all the way back from ground zero again. So to control someone's retinopathy, they really need intensive therapy depending on where they come. And that's the reason why you want to get the disease before it gets very advanced. If you get it before it's very advanced, you may not need a significant amount of therapy. And even those eyes that have great burdens, but they got to come in frequently to see a retina specialist, after 2 or 3 years, studies have shown that you may have to come in just 2 or 3 times a year just for maintenance therapy. But trying to get someone to that point is a big deal. And I'm going to keep pushing screening, because screening for me, and it's even higher in African American and the Latino populations, we don't see those patients early enough. 50% of America don't come in by the ADA guidelines, which is once a year, and it is higher in certain populations, particularly in Blacks and Latinos.
Hey, sorry, I had to let that linger a little bit because it's tough. So just for the people that are watching, understanding this, whether you're diabetic or not, you should be getting an annual eye exam. Just on GP, right? Just on general principle, as is be part of your annual routine of getting an eye exam, dilated eye exam, because as Dr. Koenig can tell you, and I've learned from talking to other ophthalmologists, they can see a lot what's going on with your body by just looking through the eyes and say that cliche that says eyes are the window to the soul, but the eyes are the window to your health. And so he can look into your ophthalmologist can look into your eyes and say, okay, oh, there might be, have you ever been tested for diabetes, right? And so that's just by going to get that exam. So there's something, and catching it early is really important, as you can tell. I'm not a fan of getting a shot in the eye, but I'm more of a fan of being able to see. And so we have to make sure there's some things that we have to recognize, and we've got to step up to the plate. And so when I hear things like compliance, adherence, those kind of fancy words that say you're not doing what you need to do, those things are really having a greater impact on you than they are on the doctor that you're not going to go see. So because Dr. Coney is going to see the patients that come see him, but if you're not going and seeing it, you're not. And so let's have some real conversations. So Dr. Coleman, what are some of those things? Dr. Coney just talked about it, but we hear the fancy term social determinants of health. What are some ways that we can help, particularly people of color, people in underserved, underrepresented communities, overcome those social determinants to be more adherent with their treatment plans, particularly if they have diabetes?
Yeah, so this is where I'm going to give a plug to my new Village Club 365, and I don't know if that was your lead-in, but I'm taking it anyway. One of the issues with just healthcare, and when we're talking about these social determinants, these are, for those who don't know what that term means, these are all the things, all the challenges and barriers that keep people from accessing the healthcare system so that they can get the services that are out there. So that includes transportation. That I live in a state in Georgia where they did not take the Affordable Care Act. They didn't take Medicaid expansion. So the only poor people in Georgia that have health insurance are children. And they're trying to figure out a way to get them off of the books. In Florida, where they also didn't take the Medicaid expansion, 1.7 million people just came off of the Medicaid rolls, and most of those people in Florida were kids. So there's this health insurance coverage. That's a problem. Access is another social determinant, because we know that a lot of times, a lot of our specialists work in academic medical centers or large hospital systems where, you know, they're not easily accessible. You got to park in their parking structure, and you might have to walk 2 miles to get to the building, and you got to pay to park, and all of those kinds of things are social determinants of health. You know, you can't find a doctor's office open on Saturday at 4 o'clock in the afternoon. Okay, that's not happening. So I tell people, you're gonna get sick, you better get sick Monday through Thursday. If you get sick on Friday, Saturday, or Sunday, you got trouble. You got big trouble, because the only place you're going to be able to go see somebody is the emergency room. And God forbid you go to the emergency room where they tell you, yo, you're just fine, go home and watch it. Because, you know, that's what's happening in this country right now. We're not going to even get into the whole abortion thing that's happening right now, where folks are sitting in parking lots waiting to get septic. Okay, so our healthcare system is a mess. And that is why Village Club 365, my new program that I launched in January, is good, because you can call the 800 number. I assign you a coach. We go through a thorough questionnaire to figure out what issues you're having. And if you've been given a diagnosis that you're not even sure if you agree with it or you know what it is, everybody needs a second opinion. So I have doctors, specialists, and internal medicine family practice who if you've been told something and you're not sure if it's really is a thing, and you want to double check, then Village Club is the place for you to be. It's called Village Club 365. It's $1 a day. And right now we're doing sort of a new program discount. So I'm going to give my 800 number, 800-788-0941. I am always the marketing person. But listen, there's so many folks out there not getting good care, especially people of color. And I am trying to stop hypertension in the diaspora. I'm not just trying to do the United States. I'm trying to do stopping hypertension in the diaspora. So that means the Caribbean and Africa and the United States and anywhere the boat left or landed. And we need to do a better job of that, because we need to know our numbers.
And I agree with that. You know, and this is a disease that really has no face, right? I mean, it affects all people, not just, you know, people of color. I think the problem is that, you know, the disparities that we've had in this country has overwhelmingly affected certain populations of people. And that's the reason why we have a significant amount of more individuals that look like you and I that are affected. And some of this may not even have to do with things we talked about. It could just be mistrust or the distrust that they have in the medical center. There's a reason why they haven't come in, not because they don't want therapy, because they just don't believe in the therapy. They have concern. When the HIV medications first came out, people were scared to take the HIV medication. I think Magic Johnson was the best thing that happened to Black people with HIV. He made it cool to actually take, you know, heart therapy. But before then, people were like, they were guinea pigs. They were very nervous because they remember the Tuskegee experiment, some of our older patients. So it's our job to meet the patients where they are. It's our job to go to the community. We didn't cause this, you know, the patients didn't cause this disparity. Physicians did. Institutions did. But it's our job to let them know, you know, help them to understand where their journey what their journey is, and how we can benefit them. And, you know, I said this before on another show, you know, I think most patients feel that doctors will have their interest. But the problem is that if patients don't feel that we listen to them, if they don't feel that we have connected with them, we have done them a disservice. They may not come back for a second appointment. And so if they don't feel like, you know, you did everything correctly in terms of how they felt because you didn't listen to them, they don't adhere to their medication. And ultimately, they are the ones that actually really get hurt. But our communities is 4 times more likely to come in with decrease in vision, 4 times more likely to end up with blindness, again, because they're coming in way too late. And again, it's a multifactorial issue. At the end of the day, people feel comfortable and people that look like them, but they just want good care at the end of the day. And they don't really care what the person looks like. But I think they feel more comfortable in telling their story because so many things have been done to them throughout their life by certain people.
Absolutely, absolutely, and you hit it right on the head. Mistrust and distrust; those are two things we talk about on a daily basis here at Black Doctor. And just for those that are watching to understand the difference, mistrust is just to understand that feeling. Just saying, "Hey, I'm not feeling something's not feeling right here. I'm mistrustful." Distrust when you've actually had an experience, when you've actually had somebody do something to you. And that distrust could be something directly to you. It could be something that was done to a family member, or it could be something that was historic, like Tuskegee. So that distrust is pervasive amongst, particularly in the Black community, but amongst communities of color. And so that is incumbent upon the healthcare system in general to try to overcome that. It's not incumbent on us to say, all right, we got to let it go. No, it's incumbent on the healthcare professionals to say, hey, look, we understand that's the history here. We're going to do what we can in order to make sure that you get the treatment that you deserve. So it's a two-way street. We're working on it. Dr. Coney, give us here in the little bit of time we have left. What's the future of diabetic retinopathy? We talked about treatments now, but how can we talk about it? I know we're going to talk about this in future shows, but kind of give people a glimpse of where we are and what the future looks like for diabetic retinopathy.
So I think it has multiple prongs. I'll start with screening because we talked about screening several times. We're moving to a different age of information, AI. There's about 50% of people that we're just not reaching early enough. And these people, they go into the Walmarts, they go into the Costco's, they go to, the shopping centers. So how can we get access to those people in a way where they may not be coming to see you? So putting in, these little medic kind of clinics in these areas, I think is important. We have great, we have the ability to actually use photographs, and those photographs are able to read a level of retinopathy. And what that does is that then it will help access people who needs to be seen earlier. And the sensitivity and specificity of a lot of these cameras are about 90%, and has been shown to be very consistent with human grading. So I think that's one. Put those cameras in places where there's high traffic and individuals that may not be seen, how we can direct them into offices. I think that's number one. Number two, I think the biggest thing is biologics. Most of our biologics right now, they have a very short acting half-life, which means that they don't last very long. That's why they come in every 4 to 6 weeks for injections. A lot of our medicines right now, once you have injection therapy, they're going out every 16 weeks between injections. And we're working on studies now trying to extend that out. We actually have medicines that last even 3 months and even up to 3 years. But it's a different class of drugs. They fall into the steroid class. So we are turning the page in terms of increasing, I'll call it, durability of a drug, which is they're lasting longer. And I think that's great, particularly for high-risk populations of people, because these individuals have a hard time coming in. They have a higher social determinants bar for multiple reasons. So this will improve, I think, their compliancy when they're coming to doctors.
Absolutely. Dr. Coleman, what's the future for diabetic treatment? Outside of Village Club 36.
Yeah, exactly. The technology, I think technology is really going to be our answer. I'm just really impressed with the amount of first of all, the specificity that the drug companies are doing now in terms of really targeting the physiology of chronic disease and coming up with agents that are really very specific. But I'm excited about the technology of monitoring. So you talked about screening. I'm really into knowing your numbers. So now there's something called remote patient monitoring that uses cellular monitors, either cellular blood pressure cuffs, cellular blood glucose monitors. They have weight scales. They have ways for you to figure out your oxygen saturation. All of these things will be able to put people's numbers onto their phone so they can see it and track it and see if the numbers are getting better or worse. It allows you to share it with your family members, which is really good, especially for our elderly patients. But it also allows you to share it with your doctor and your pharmacist. So therefore, we're going to know when your numbers are up because we get alerted. We set thresholds for where your numbers should be. And if you get above those thresholds, I get alerted. And then I can go give you a ring, give you a call, try to figure out what's going on. Did you not take medicine? Are you on the right medicine? What's going on? Did you just have an argument with your husband or your wife? And that's why your blood pressure is high. I just need to know. You got to tell sister what's going on. So this is, I think, the leading edge of diabetes, and then continuing to come up with these targeted therapies that, like, with injections once a week, as having to take a medication every day. In the cholesterol space, we're doing injections for cholesterol once a month. So I think that's where medicine is going, so that we are more targeted and more specific. But I would like everyone to, talk to their remote patient monitoring is available right now. We're actually doing it with our doctors at Healing Our Village. Ask your doctor about it. Everybody should be on one of those technologies if they have high blood pressure or if they have a high blood sugar. But can I just say one really quick thing?
Sure.
Okay, I want to just say that where you get your information is critical. And I really want people to stop getting their information from the internet. Okay, seriously, people. Okay, talking about distrust, but yet I don't know Google. Do you know Google? Have you met Google? I don't know Google. I don't know Google's mama. I don't know Google's favorite color or Google's favorite restaurant. But yes, I asked Google, and whatever Google says, I believe. So you don't know, I did COVID for the last 2.5 years, and you don't know how many Black people died of COVID because they were listening to the internet instead of listening to doctors that spent their lives learning to be able to do what they do. So if you guys don't do anything else, please get your information from credible sources.
It's a catch-22 because we are on the internet right now. So
I know, and I'm credible, and so is Dr. Coney.
Absolutely.
And Black Doctors is credible. So you are a credible source. You're not Google.
We like to think that we are. Yeah. So as we're wrapping up here, I want to kind of point out some of the things, to highlight some of the things we've talked about in this conversation. Number one, know your numbers, and that's your blood sugar numbers. Understanding the difference between blood sugar and A1C, we've got to make sure that we get that A1C because that gives you a greater snapshot. Get that down. Number two, you should be getting a dilated eye exam on an annual basis, particularly if you're over the age of 40. Is that right, Dr. Coney? Over the age of 40, you should be getting that automatically. If you're diabetic, it should start automatically. Type 1 is a little bit different because that's a different type of diabetes. But type 2 diabetics, as soon as you're diagnosed, you should be going and you should be going on an annual basis to get that eye exam. Number three, have great conversations with your doctor. Explain to them when they give you all those forms, when you go fill them out at the beginning, rely as much information as you can on there because that's going to help them work with you, and particularly have some real conversation with them. And they say, okay, I need you to come back. When doctors say, I need you to come back, say, doc, hey, I had to take 2 buses. I had to get somebody to watch my child, and I had to take a day off from work to come here today. Is there any other way? Is just having that conversation could go a long way in terms of keeping that communication relationship open and having a doctor kind of think outside of the box in terms of your treatment instead of just writing on there, did not show up, patient is not adherent. So those are the little things that we can do. Is there anything else that I missed? Because I know we talked about microvascular and macrovascular. There's a whole lot of things that we talked about in terms of what could happen, but I'm talking about what people can do and can take away from this. And that's saying, hey, look, have a primary care physician, see them on a regular basis, know your numbers, and also include getting a annual eye exam as part of your health regimen. I know we just want to go to our main doctor and look in our eyes with the light and say, we're good. No, that's not good enough, particularly as we get older. We need to have a full dilated. That means somebody's got to take you because you can't drive after that because it's got to come back. But have a full dilated exam. So I'll let you to Dr. Coney. Any other last thoughts that you want to kind of leave people with, the things that they can do in order to lower their chance of developing retinopathy, particularly if they're diabetic?
Well, I think it's going to overlap with Dr. Coleman, but I leave my patients something they can understand. I'm a visual person, and so I leave them with the five. Really, it's their ABCs. I tell them I want the A1C less than 7. B is for blood pressure. I want the blood pressure less than 140/80. Their cholesterol, diet, and exercise. And I always throw smoking in there as well. So those are the things I tell my patients that if they control those things, they will die of something else besides their diabetes. And for me, that's critical. And the reason why, again, that screening is critical, because we know that once individuals are diagnosed with we know that there are people that have diabetes, and 50% of people have sight-threatening problems and are not aware of it. And that's the reason why the screening piece is critical. And it's also critical because Blacks and Latinos have a 4% risk of blindness. And I think that for me, if you understand that piece, go get your eye checked. And then the last piece is that some of these people are seeing doctors, but they're not seeing an eye specialist. So if you have kidney problems, I know you have eye problems. Eye and kidneys go hand in hand. And oftentimes I can see retinopathy, they may be fine, but I'll let them know, you know what, these changes are going on in your kidney. They just haven't manifested themselves yet. So I am the one of the few people that have a luxury of looking in for, a couple of minutes to say, hey, this is what's going on, before you see it in your feet, before you see it in your heart, before you see it in your kidneys, and before you see it in your brain. And the eye is something very special. And when I say it's the keys to the soul, it is definitely the keys to the soul, because I know where you're going if it's left untreated.
Absolutely. Dr. Coleman.
Yeah, I just real quick. The one thing we didn't do a lot of talking about tonight is lifestyle changes. And in the area of diabetes, that's diet and exercise. So, the exercise is your 150 minutes a week, right? Where you're trying to get your steps in. And let me tell you, it's impossible to get to 10,000 steps unless you go out for an hour and a half, and intentionally walk during that time. And the other thing I've learned just recently is walking fast is not the way to burn fat. So I've had to slow my pace down on my walk in order so I can stay in that fat burning segment of my heart rate. So I want to say that. So I'm really trying. I can usually get my 8,000 in. That 10,000 is hard, and I try to do that 3 or 4 times a week. But every day is difficult. But you got to try. I'm 70 years old with 2 hip surgeries, people. So I don't want to hear it. Okay, number 1. Number 2. I want to say that, watching what you eat, your carbohydrates, your starches, your fats, trying to decrease your portions. All of that is really important. There's a comment in the chat that says many doctors want to put you on unnecessary drugs. So, drugs are something that work if for a diagnosis of something that you have. So if your doctor knows what's going on, then they shouldn't be putting you on unnecessary drugs. But I actually agree with you, because there's a lot of drugs that people are on that they should no longer be on. They should have been used during that time period when they were having that problem, but drugs get added and never get subtracted. So I agree with that statement, but it's not that they're putting you on, they're just not getting you off of some stuff that you shouldn't be on. So all of that is also important.
Absolutely. And you have the power of getting yourself off, and that is by those 5 things that Dr. Coney was talking about. Keep your A1C down, blood pressure. If you can work on those every day. Every time you sit down with a plate of food, you are making a determination of what's going to happen to your blood sugar and what's going to happen to your blood pressure. So you got a lot of salt and sugar, guess what? Those things are going to go up. You lower that, you do that walking that Dr. Coleman was talking about, you can lower both of those things and get off of those medications. So thank you both. This has been a fantastic discussion. I love the energy. I love the excitement. I got to go now downstairs and try to eat something that's going to be healthy, because y'all scared me away from microvascular and macrovascular. I don't know what. I just want a plate full of food, but we're gonna make it work. Again, we're gonna be continuing this series on the Open Your Eyes series on with Dr. Coney on a monthly basis. So check us out once a month, every month here. We're going to be talking about diabetic retinopathy, and we're going to talk about all facets of it. Dr. Coney does a great job. He'll bring some pictures sometimes so you can actually see what it looks like. And we're going to talk to some patients. We're going to talk about clinical trials, all part of this program and the cutting edge of clinical trials and what that is, and let Black people get over the uneasiness of the whole clinical trial thing. They are really saving lives and changing how healthcare interacts with our population. But we've got to, and my favorite statement is, involvement improves outcomes. And so you got to get involved in order to improve those outcomes. So look forward to this series. This is one of many. Thank you, Dr. Coleman. It's always a pleasure to have you. Y'all go check out Healing Our Village. She's got a whole YouTube channel. She does Sugar Busters, talking about how to lower everything you need, diabetes. Go see Dr. Coleman. I'm telling you, you see the energy. She said she was 70 with 2 hip surgeries. You see the energy? I need to go see Dr. Coleman. And with that, I'll say thank you, and we'll have a good night. We'll see you next time.
All right. Thank you. Take care, everybody.